As a patient, you have a concern about a health or medical issue, so you see a doctor and you get your health care. Pretty simple, right? All of us have and will continue to be part of the healthcare ecosystem, but very few of us understand the level of work and the team approach that is necessary to ensure a great patient experience from start to finish. Here's what it takes to care for just one patient who is experiencing vision problems and the many touch points along their way at Austin Eye. Healthcare should be easy, right? You're a patient, you have a problem, you see a doctor, problem solved. Easy, right? It's complicated. Let's go through it step by step. You're a patient, you have a problem. Who do you see for this problem? Where do you go? So you do some research. You look online, maybe another doctor recommends somebody, maybe a friend or family recommends, but ultimately you make a choice. One doctor, you call that doctor, or you contact them online, which usually results in an inbound phone call, which is either a machine or a human.
Oh, probably 18 months ago, quite a while ago. I couldn't read the traffic signs at night. And so then I realized I needed to do something about it. I'd wear long distance glasses at night, and then I had some readers, and then ultimately I needed shades that had long distance too. I'm traveling quite a bit, flying, and so always having to have a couple of pairs of glasses with you was frankly a pain in the neck. Well, it was my daughter Nicole. She came and saw you, had a very successful outcome, and she was almost evangelical about it. And so she knew I was having some problems, so she said, you need to get this done.
In our case, it's a human. That human schedules your appointment.
Okay. I'd add him an account in CompuLink, and I would get information from him about what type of medical insurance he's on, his phone number, date of birth. Once I get their date of birth and I kind of know their age and what they're complaining of, you can kind of deduce if they are a possible cataract patient. If they've ever had, you're asking them if they've ever had eye surgery before, any past procedures, what they're really wanting to come in for, kind of dig a little deeper to see what their need is. If they didn't necessarily say cataracts, but they are the age that would start happening, and what they're complaining of, like, issues driving at night, vision has progressively gotten worse over time, I would put them in like a cataract evaluation if they meet the criteria. Get their medical insurance, make sure we're in network, inform them we don't take vision plans, because a lot of the time when they're calling an eye doctor, they think we take a vision plan, and we don't. And then I would schedule them accordingly. Their photo ID and their insurance cards, and a list of any medications that they take, any glasses that they wear. And then I'll ask them to fill out our forms beforehand on our website, austineye.com. Yeah, we direct them to visit our website beforehand to fill out their patient forms, like their medical history and their demographic information. And then I always, because I've worked in insurance, will kind of, once I know their insurance information, I'll let them know any charges that they might have, like let them know we are a specialist, so if you have a specialist copay, that's what it would be for a visit with us, as well as the refraction fee, because if a lot of patients are coming from like seeing ODs in their history, they're not necessarily used to paying for that as a separate charge. It's kind of included from what I've learned in like optometry practices. And so I'll let them know, because that's what a lot of the time, I came from being a receptionist when I first started working here. So that's something that really threw patients off, was having a copay and an exam fee in addition to a refraction fee. So I always try to let people know about that. Oh, so we do ask them for their email, and they'll either get an automated email reminder from our reminder system that directs them to the web page, or if they seem like someone who needs a little more direction, we will personally send them an email with like the links to the website or with the forms filled out. It's called TalkSoft right now. They send, if we have an email in CompuLink, it will send them an email 3 days before their appointment. It'll say, like, you have an appointment scheduled at Austin Eye at this location. So it'll say 40th or Jollyville. It'll also say which doctor and which time. It has a link to our website to fill out the patient forms, and then it reminds them to come a little bit early and that we don't take vision insurance. If they confirm via the email, they get no further reminders. If they ignore the email, then they will get a text message 2 days before. If they confirm via the text, they'll get no further reminders. But if they ignore the text, then they'll get a phone call the day before.
Well, I just found the service level very professional, whether I was actually in the office or whether I was on the phone. They were always very polite and tried to be very clear about what was going on. And so I thought the team that I ever had interactions with in terms of just the telephone were really fine and good. And
did you ask a lot of questions?
I asked questions, and they were very patient with me and at the same time professional. They didn't think, what's this old dude doing asking all these questions? Why doesn't he read about it? Or nothing like that. No attitude at all. So whatever you've done or whatever they're drinking or whatever you put in the water, I want some of it too to give to my staff. You only get one chance to make a first impression, and she did. Well, I thought there might be a lot of sitting around. I mean, you go to some doctor's offices, they say 10:30, and you're there early, and maybe they see you half an hour, 45 minutes later. I'm a fairly busy guy, and that really agitates me. Mm-hmm. None of that. So they saw me on time. They were polite. They were very nurturing and trying to tell me what might happen and what they were going to do and why they were doing it. So first impression was fine office. Looked like it was well organised. Everybody seemed to be working. Nobody seemed to be like they were chatting away in the corner. None of that. So, and I got seen very quickly, and I signed in and sat down. And I thought, now we'll see how long this takes. And I think within a few minutes, they called my name.
You travel and you arrive for your first appointment. You're met by a patient coordinator. So the patient coordinator is your first impression for the medical practice.
2 days before the patient visit, I write down their basic information on a router. I also include the forms that they'll need to fill out. And if I already have their insurance information, I go ahead and write that on the router. If I don't, then I highlight that I need to get their driver's license and their insurance information when they come in. I greet the customer when they first come in. I'll ask them if they have their driver's license and their insurance card. I'll also ask them if they pre-filled out paperwork online. If not, I give them the proper paperwork and I tell them what they'll need to fill out, what they'll need to sign on the iPad, if they want to do the optomap or not. When the patient comes in at the beginning of their visit, I give them 5 forms to fill out. The demographics form, the HIPAA consent form, new patient medical general history form, the payment policy of the practice, where it gives you the general rules of our practice, refraction policy as well as at the bottom, and the optional optomap retinal screening. The 2 documents that I ask the patients to fill out on the iPad or sign on the iPad is the payment policy and the optomap retinal screening. Insurance does not cover it. It's $55 if the patient wants to elect to have this done. If they don't, they just simply tell me and we just check that they don't want to have this done. That's all the new patient paperwork that I have. New patients, they're eager to know what is going to be included in the visit, what will be covered by their insurance and what won't be, what will collect up front, out of pocket for their visit. So from the moment the person checks in and they give me their IDs and I give them their forms, I would say generally it's about 8 to 15 minutes that process can take, depending on how fast the patient fills out their paperwork and they get it turned back into me. If they already have their paperwork filled out online, that can take like 5 to 8 minutes, like up at the front to being put back in the bin for the tech. So I'll only enter in demographics and HIPAA information, and then I make sure that they sign the payment policy and Optos. I give the medical form to the tech, which they will have that in the patient's chart, and they will enter that into iDoc.
Then in our practice, you're taken back for your initial assessment by a technician, an ophthalmic technician. And that ophthalmic technician does diagnostic tests, an initial assessment, patient education, begins financial disclosures.
Chart gets put in here, any available tech that looks around this area goes to pick it up, and then we go back to our desk and start the chart workup process. Chart workup process, we take a look at their paperwork, see what their chief complaint is, document any medications, update medical history, surgical history, ocular history, that kind of thing. And then the technicians, for accountability purposes, we mark off the patient name. There's a schedule over here that has all the patient's name for the morning or the afternoon, and we mark off the patient that we're going to work with, and we put our initials next to it, and that kind of signifies who's working with that particular patient. And then we go back to the workup area and we kind of start our process in terms of kind of what different types of testing they do. So, you know, our most popular type of exam is a cataract evaluation, and so we'll typically get, if they're a new patient, we'll turn the light on, get a photograph for their EMR record, photograph with this little camera over here. Well, you do this test for almost any patient that comes in. It's an auto-refraction, and it's very useful because if the patient's complaining of blurry vision but they don't wear any glasses, we can at least get a really quick refraction to kind of see where they are in terms of how their eyes focus. So we get this pretty much on every patient. We ask them to take a seat. We kind of give them a brief summary of what it does. Auto-refraction kind of measures how light focuses through your eyes and kind of gives us a printout. And then when you look through the ocular, and I'll go ahead and turn this on, most patients should see a balloon on a road. This is kind of their generalized printout. This is not any particular patient, it's just the last printout that is available, and it kind of gives us what we need to put into the phoropter, which is one of the instruments that we'll use in the exam room, and we'll kind of get to that. I kind of be like, okay, we'll get some extra testing done to kind of see what's going on with your vision, and then the doctor will kind of go over everything with you and kind of see what's going on with the eyes. Usually if they've signed for the Optos picture, I'll get my Optos picture over here. I kind of just explain to them, this is that additional retinal imaging that you opted to have for. It takes a good wide angle picture of the back of each eye, and we get a good documentation of it, or a baseline image of what you came in with. And they usually kind of respond, oh, that's pretty cool technology, that kind of thing. And then I'll usually head into this next room over here. This is the OCT, some different types of retinal imaging that we do for our patients, and basically kind of gives us a different view of, say, their retinas, that kind of thing. I say that this particular instrument gives us a different view of the retina. A lot of people say, oh, I just did the retina scan 2 minutes ago. Like, yeah, this just gives us a different view for the doctor, kind of get a look at every single structure of the eye. Usually, if I kind of preference with the doctor will look at everything, they kind of nod with me and they don't really ask too many questions in that regard. If they're really inquisitive, then I ask them, oh, well, the optic nerve readings that we get measure the amount of nerve fiber tissue that you have in the eyes, and kind of checks for any signs of possible glaucoma. I usually don't go that far for every patient because it's kind of a mouthful, but if they're really wanting to know exactly what I'm doing, like from start to finish, I'll go a little bit more into detail. But for the most part, I just say scans of the retina and the optic nerve to kind of keep it simple, but still knowledgeable enough so they know what they're doing. The next stop is kind of usually in these two instruments. I usually get them over to the lens star. You get several different measurements of your eye. Again, if they ask specifically, I go and say, oh, it measures axial length, any sort of astigmatism, the thickness of your cornea, that kind of thing. Like, oh, okay, that sounds good. This machine, I would say, of all the machines that we have, this is the number one most important one for cataract surgery. It's important that the technician does it correctly and that they get good values for the patient. This is called the eye trace. This actually gets two different kinds of measurements. It gets a refraction through this instrument as in addition to a corneal topography, and that essentially means a mapping of the front surface of the eye, and that kind of checks for any sort of irregular astigmatism that may be present in the eye, or if they have any sort of corneal pathology present. All right, then we've gotten these tests, so I usually say, hey, okay, we've gotten everything done out here, we'll head into an exam room. So I'll have them go ahead and take a seat. I'll write any additional chief complaint that they need, update allergies and who they're here with and how they heard about our clinic. After that point, I'll now verify, family history of ocular issues, glaucoma, macular degeneration, retinal detachment, and then I'll go ahead and check with their vision. check their vision. Test their vision, I'll document what their vision is with correction, whether they're wearing their glasses, contacts, that kind of thing. Ask them to take off their glasses, check the distance vision again uncorrected, and then I'll also check for uncorrected near vision. So those are kind of the main things that we kind of get for really any patient that may become a surgical patient. I'll check glare testing, do vitals with the blood pressure cuff. Myself, I use my cell phone to actually show eye imaginations. I show them kind of a little bit of a slideshow of what cataracts are. And so we'll open this up. And I usually tell them verbatim, this is cross-section of the eye, front of the eye, this is the back that I call the retina. And then it shows them how light enters in through the eye, through the lens, focuses on the retina. And I say over time, the lens in our eye begins to change. It begins to get more cloudy, and we call this change a cataract. And then when light enters in through an eye with a cataract, it kind of scatters in different directions. You start noticing blurred vision kind of during the day and blurred vision kind of when driving at night. And so I go in, well, we would remove your natural lens, remove the cataract, and place in a new lens that's nice and clear. And the new lens doesn't get cloudy again, and it kind of stays with you for the rest of your life. And so I'll explain the chart, and if they're interested in the premium surgery, I kind of go a little bit more in detail, specifically with the Symphony lens, kind of pros and cons of the other premium lenses, if they actually wonder about these two lenses. I'll likely, if they're really interested in surgery, I'll open the precertification spreadsheet, which allows Amanda, our insurance coordinator, to kind of contact the patient's medical insurance and give me, the technician, kind of an estimation to kind of go over with them in terms of what their estimated out-of-pocket expense would be with our practice and the surgery that they choose. And by now, I've probably spent maybe about 35-ish minutes all together with the testing and the discussion. And then by that amount of time, they're either kind of the patient and whoever they came in with are kind of discussing with each other as I kind of do my final editing on the chart, save, and get ready to put the chart back onto the bin outside of the door where the physician will be notified when the patient's ready, and then they'll kind of come in and go from there. I tell the doctor kind of what we discuss, kind of do it in a brief summary as best I can. So say if a patient was considering cataract surgery, I'll be like, we discussed the different lens options. They're leaning more towards the Symphony lens, and they're looking to schedule pretty soon.
And then they pass you to the ophthalmologist, who does an assessment and then formulates a plan of treatment. The medical decision, MD.
So the technician has handed the patient's chart over to me. I review the patient record, and I just look at a brief synopsis of what's going on. I check what their uncorrected vision is, far and near, what their prescription is. I look at their age and their past ocular history. And then I will go through a sequence of reviewing the diagnostic tests that were acquired by the technician. I will look at the corneal topography, and then I will look at the retinal imaging. So I'll look at a photograph of their retina, and that's a high definition photograph, what we call the optos. And then I'll review the scans of the retina, the OCT, and make sure everything's normal. And then I'll just examine the patient. And the examination of the patient, I'm looking at their ocular health, the condition of their cornea, their pupils, their extraocular movements, the condition of their lens, the condition of their retina, checking their pressure. So after I've reviewed the patient's record, examined the patient, and reviewed the diagnostic imaging, I ask the technician, so what have you guys discussed already? And the technician will tell me what they discuss. Usually it's some type of decline in their vision, and in this particular instance it's a decline in vision related to the onset of a cataract. So the patient has already been educated about what a cataract is and what their options are, and I simply say to the patient, you do have a cataract, and if you have cataract surgery it will help you see better. What questions do you have? For most patients, they'll simply say, the technician has already done an outstanding job of explaining everything to me. I'm ready to proceed. And then I go, which eye would you like to have surgery on first? They'll pick the eye, and then we'll say, we'll take great care of you, and we'll help you see better, and we'll turn you back over to the technician. And then they'll help the patient go through the next phase of the process. So my total time that I spend with the patient in the exam room is usually only 5 to 10 minutes. Most of the times our technicians are so good that it'll only take me about 5 to 6 minutes. So it's very efficient. And I don't think the patients feel rushed because they were being given correct information the whole way along the process. So I'm just confirming most of the findings that have already been gleaned during the preoperative testing phase.
Then you're passed back to the ophthalmic technician who does informed consent, completes the financial disclosures, and then checks out and schedules the patient for their procedure. Oh, the technician also does the chart check, the final chart check, to make sure all the information was entered accurately in the medical record and billed and coded appropriately.
I basically ask them to just kind of follow me, and then we go into a separate conference room where I start a consent video and get the rest of the paperwork ready. And then I usually actually, what I found useful is I take the laptop and I actually bring it with me into that little video room and I schedule with them. It kind of helps with patient flow because I don't like having people that are indecisive just be standing at the counter kind of debating with me between dates, follow-ups, that kind of thing. I'd rather get all that done in a private setting so that they don't kind of make a cue for everyone else. I'll start the video, leave the room, and then that's when I get my paperwork ready, and then I kind of time it about when the video is finished. I'll kind of enter the room with the laptop. In that 14 minutes, what I try to do, and I try to get all of the patient labels onto the paperwork, fill out the necessary information that I need, get all the printouts that I need in terms of insurance information or demographics, medical history list, that kind of thing, and try to get all that prepped beforehand. Maybe if I still have a moment, I enter in the charges that I know I'm going to collect in CompuLink. That way, ideally, if everything is done, if I've not been interrupted in any sort of way, I can get all that done. And the only thing I have to do when I'm done with the patient, sign the paperwork, maybe sign my own name for the signature, and then just kind of get it together for the physician. And then I'll check out the patient, collect however much I need to collect. So maybe the whole paperwork scheduling process, 30 minutes. Yes, I check the patient out. Take their copayment, eye drops, whatever, refraction charge, optos charge, I take care of that. Preoperative instructions are done in the video room. I kind of go over what exactly they'll need, that kind of thing.
I was pleased that they were able to tell me in layman's language what was going on and what they were trying to do, and they were trying to get measurements so they could figure out what I really needed. So that went pretty smoothly, and so it was a non-event in that sense. Yeah, very, very, very helpful. I was professional all the way through. You were very professional. You were gentlemanly. You were not too laid back, not too intense either. Kind of a nice attitude and a calming influence, I think, basically. So that was good. And you didn't seem to be in a hurry. Okay. Sometimes you go in the doctor's offices and they're rushing around and they're already half an hour late, and there was none of that. So that was very nice.
Then you have an insurance administrator who does the pre-certification process.
As soon as the tech puts it in our Google pre-cert sheet, they'll put in the account number and then what surgery they're getting, and then that's when I go into play. I get an email, or I have the Google pre-cert already on my desktop.
So this is basically what my screen usually always looks like. Make sure this is in the background because then I can see when they're typing, and then I can see when some...
Oh, it's just entered in real time, so it's always on your desktop.
Always on my desktop.
And that's how you find out.
Yes, and if I'm not informed like on here.
So this is always on your desktop, and when something is entered anywhere at either office, it pops up.
Correct, yeah,
and
immediately.
About how many of these do you get a day?
Lately, it's been maybe like 20.
20 a day.
And then I get into their CompuLink and I call their insurance.
Okay.
So, and you said it was Medicare?
Yeah.
So that's the easiest one. So, because it's all IVR. I don't ever have to talk to a rep or be on hold.
IVR, what's that?
That's the automated system.
Okay.
So I get all the information from there. I call that and I get their benefits, like their deductible, their co-insurance, and I basically figure out how much insurance pays and how much the patient is responsible for out of pocket. For cataract surgery, that call would probably be like 4 minutes. 3-4 minutes.
Oh, very fast.
Very fast. Medicare is the easiest.
Private insurance, what about, how long does that take?
Anywhere from like 20 to 40. Because if I have to be on hold, I will be on hold for a long time. Because it allows the facility to know what the patient pays, which is important, and it gives the patient information on what their insurance pays as well. So payment, very important. I usually just fill out the pre-cert sheet. So this is what a Medicare pre-cert sheet looks like.
Okay.
It's usually, I have some of it already filled out previously because those numbers never change. So I just basically fill in the blank. And then if they have a secondary insurance, they'll go right there, and then all the math goes right here, and then the patient's responsibilities are right there. I scan it into their iDoc, and then I give it to them, or I email it to them if they're at the other location.
Okay, good. And you handle this for both offices?
Both offices.
Who backs you up?
Usually it's me, but I know Sierra, Chris, and Sarah are available too if I need it.
With the patient who's wanting to schedule cataract surgery.
So I've already scheduled surgery with them. I've collected the amount that I needed to collect, co-payment, refraction, PGB, that kind of thing. And then we've said our goodbyes, the patient's leaving, and then I have basically the completed chart in my hand. I go back to my desk, assuming there's not another patient that needs to be worked with. If I have an idle moment, I'll finish any signatures that I need to do, kind of get everything prepped, make sure my lens start printouts are available for the physician and any other printouts that I need, and kind of get that all squared away. And then I place the chart on the physician's desk for them to sign and review. Chart checking, ideally, in the ideal circumstances, we do the chart checking the same day as the chart's closed, meaning that we verify that all the charges and diagnostic codes are correct in the EMR system, and we verify that the computing charges, the patient management system, is correct as well. And ideally, all of the patient's charts for that day has been done that particular day. We have a turnover time of 3 days, 3 business days, to complete this task for our meaningful use units, but we all try to pitch in and do it within the first day. Checking one chart, assuming everything is correct, maybe about a minute to 2 minutes.
And then the chart goes back to the ophthalmologist for final review, and a surgical plan is created. So the chart's made it back to my desk. At the end of the day, this patient is going to have cataract surgery, so I'm going to review the chart and pick the lens implant. So I review the different lens calculation formulas, and I pick the lens, and I figure out if they have astigmatism and how we're going to manage their astigmatism at the time of their surgery. So I review all the prior documentation, I pick the lens implant, and then I complete the preoperative paperwork and sign off on everything. I double check the forms that were filled out and the plan. So the total time I spend with each chart at the end of the day is about 5 to 10 minutes to review it, sign off on everything, print out a plan, calculate the lens, and then I pass it on to the nurses for their review. And then that chart is passed on to the registered nurses, or RNs, who then review the chart. Then what happens to that chart?
So we go through the paperwork, we make sure that everything is completed and signed. We look at patient medically, we look at their blood pressure, we look at any drug allergies, anything in their history that would be pertinent for us, especially mobility issues. Does this patient have profound cardiac or respiratory issues that are going to be something that we're going to need to look out for? Are they on oxygen? So we're looking at the whole patient.
And also we look to see if we need to call the patient prior to surgery to discuss the reaction to certain medications or allergies, or if they take a medication similar to Valium, we'll ask them about dosage, how often they take it, so that we're not duplicating medications.
So to have an unexpected issue with a patient medically slows us down. So to have a patient whose blood pressure is out of control, and we weren't aware of that, or we weren't aware of them needing to be seen somewhere prior, so it's very important for them to have that baseline blood pressure taken in the clinic.
I mean, we want to make sure everything's filled out correctly. And then sometimes if their blood pressure's high and they're not on blood pressure medications, then we reach out to the physician asking them, do we want that patient to see a primary care physician prior to surgery to discuss their blood pressure, so they're not coming here with crazy blood pressure.
Part of the process is also pulling the lens. So we're looking at the IOL sheets, we're looking at the physician plan, we're making sure that everything matches, and then we're pulling the lens. So then it goes to Gloria's bins on her desk.
I mean, sometimes like checking the chart and the paperwork, if stuff's not signed, then you're finding people where you're missing signatures, trying to find the tech or the doctor, making sure everything's signed prior to surgery. So we really don't want to do that day of surgery. And if there's any consents that haven't been signed, we flag that and we give that to Gloria so that can be signed as soon as they check in.
And then the patient's chart is passed on to the surgical coordinators to prepare and review the chart and then finalize the surgical schedule.
Okay, so what we do is we typically do a day at a time. So like we have, if you look at the surgery schedule, we'll copy the entire day surgery on this little worksheet that we have. That has all the patients, what type of surgery they have, you know, what doctor, what time, everything that you could need for what we do. 2 business days beforehand. So we'll go find the patient's chart. So for example, we'll do this first patient. Usually if the nurses have checked it, everything's good to go.
Okay.
So it's usually in their clinic chart. We'll pull everything out, make sure that, you know, it's the right eye that matches the schedule, make sure all the paperwork is cohesive, you know, everything's filled out, everything's signed by the doctor or the patient. And then we put it in a certain order. So it's actually about 7 pages. So these are pages that we fill out for every patient. So, you know, we go through, circle the predetermined amount of value, the doctors, which eye we're doing, what type of surgery it is. This is the second page. Again, kind of the same information, but just the safe surgery checklist. So, you know, what type of lens, their follow-up phone call number. This is the operative note. Once all that's done, then we print the labels with the patient information, their date of birth, the doctor number, and then the lens type. And then we sticker the whole chart. And then that's it for the surgical charts. And then after that, we create the schedule, the surgical schedule. I don't have one as an example, but the one that goes in the ORs, you know, like and then we charge them up, put them in the ledger, charge them up for the surgical date so it can be sent to insurance, and then when they check in, the balance is there, so we can collect payment from the patient. We always charge up 1 day before, and that's pretty much it. The nurses usually pull the lens.
Okay.
Yeah, and then, but if they don't or they haven't had a chance to, we can go pull them as well. We just do like 1 chart at a time, put it together, finish it, label it, and then put it in the spot that it goes to for the doctor to check, and then you guys hand it off to the nurses. I call the patients 2 business days technically before, like down the list, to give them the arrival times that we set. Because if we do too early, then it changes a lot. So people keep getting added, or somebody needs to go later or earlier. So we found that 2 days is a good balance between that. That gives them enough time to be able to schedule a ride, but not so where we're calling them 3 or 4 times, changing the surgery time. I mean, luckily a lot of people look at the surgery charts, but we a lot of times check and balance ourselves. In terms of charging up the ledgers, Kristen helps a lot to check after we charge it up to make sure that doctor's right, the eye is right. If there's any modifiers on there, then those are right. So she helps a lot with that. But then for ours, pretty much each other, and then the nurses as well. They'll go through it and double check everything as well. So hopefully the only thing we need to do is just check them in and collect their payment, and everything else should be prepped the day before. So we don't do too much typically the day of surgery besides take their payment at check-in. We'll page the nurses or call back there and tell them that, you know, number 4 is here, and then they'll come up here and get that.
Then the RNs prepare for surgery, and then ultimately the patient arrives for surgery. While they're in our ambulatory surgical center, they go through a check-in and preoperative assessment.
Day before surgery, we go through all the charts and enter aura. Most of the staff pre-sign and go through the paperwork.
The OR nurse.
Yeah, whoever's going to circulate goes through the paperwork day before for the surgical patients. Make sure that the plans make sense.
Well, the day before surgery, we get all the stuff for setup. So Gloria makes little packets of their discharge paperwork, their wristband. Okay,
Yeah.
so we bring all that back, and we set up all the little bags that patients go home with day of surgery. We set that up the day before.
And Valium.
And Valium, we set that up the day before as well.
And then all the surgical packs, each surgery supplies.
So we get everything ready for the day. But we bring them back. We verify all their date of birth, what surgery we're doing, allergies, all that before they even get back here, just to make sure we're all on the same page.
So one of the questions that we ask is, have they eaten? Because that's a factor for us. We prefer that they eat before we give them Valium. So one of the things that can actually slow things down a lot is if the patient hasn't eaten, because we have to stop and let them eat before we can give them Valium. And with many patients in our older demographic, it's surprising how long that can take. So that's one of the things that actually is surprising in terms of slowing down the process.
I mean, we make sure that they've eaten something. We make sure that they started their PG/B drop the day before. Make sure that they have a ride home, who that person is. Are they staying? Are they leaving? Phone numbers. I mean, no contact lenses, no hearing aids, that whole process. Any changes in medications or medical history since they were here. We go over the discharge instructions prior to giving them Valium. They get a copy at the pre-op. We tell them that. We tell them they're going to go home with a copy, and then they're going to watch a video. So we don't actually read through those discharge instructions with them. We show them the video. But they sign the discharge instructions first before they take Valium. So we typically give Valium, and we check some vital signs before we start drops. We try to get our first set in and then start doing education on surgical process. So we go through the entire surgical process with the patient from start to finish. So we start with the laser room if they're going to laser, everything they're going to experience in that room, what they're going to feel sensation-wise, what we're going to be doing during that time. And then we go all the way to the operating room, putting blood pressure cuffs on their arm, different sensations they're going to feel, eyelid holders, being still, not moving. If we tell you to look up, we want you moving your eyes, not your head. We go through all those steps with the patient. And a lot of times patients have questions that can take a while to go through.
Right.
So we try to do a set of drops and then talk and then see how they dilate, and then we'll do more drops. Then they watch their discharge video after we're done with drops, and then they go into surgery.
Well, I guess you're kind of thinking somebody's going to be poking around in my eye. If I get a little speck in my eye, I'm scratching it and going, you know.
Yeah.
So it's, I guess there's a fear factor there. And I think that was addressed by everybody being very calm and trying to make sure that you kept calm, and just by being able to tell you what was going on and what the next part of the process was, and so you became, I guess, quite calm because you understood what was going to happen. They were a calming presence, and remember, I'm thinking they're going to stick something in my eye, and so they were trying to explain very calmly and professionally what was going to go on, and so on. And then, of course, I took some Valium, and I started to be woozy is not the right word, but not perhaps as alert as I should be. But they were still there explaining each part of the process, why I was sitting in this chair and why I was going to the next place, and so I guess it was almost relaxing.
And then they're taken to the operating room for surgery, where there's also the RN does the check-in. There's an RN, the ophthalmologist, and a surgical tech in surgery, and then they have their post-operative care in our surgery center by the RN as well.
Okay, day of surgery, I want the chart to be put together. We want to know what lens choice the doctor already has made. The lens star reflects what lens we've already pulled, what's in IDOC. We want to verify that all of that is done in advance. The nurses like to check the chart a day or two before surgery. Kay on Monday morning checks her charts before surgery, so she has to do that super quick. But the nurses have already entered the aura for her on Friday, so that makes it pretty quick. Tuesday, Wednesday, and Thursday, we need to enter aura for all of those patients in advance, and then check it day of surgery. So for the patient, we want it to seem seamless. Like we've already done all that work. When we walk in, the nurse that's getting the patient ready can just verify that all the paperwork's there. So before surgery, I've already checked their charts. I've already checked for my disclosure form, my pre-anesthetic evaluation form. I've already checked for their consent, and I've already checked their LensStar. However, when they do come into the operating room, we're going to do, most importantly, a timeout where we're going to verify all of their information, that we have the correct eye. Patient isn't allergic to anything that we're going to give them in the operating room. We're going to go through all of that, and then patient lays back. We're going to check their vital signs. We're going to get a blood pressure, pulse, respiration, and their pulse ox. We're going to be monitoring those same vital signs throughout the time they're in surgery. Every 5 minutes, we're going to monitor their pulse and their pulse ox and make sure that it's in place. As patient is in surgery, we're going to check our aura data once more just to verify that's correct. We're going to check IDOC to make sure it all matches, verify the lens that we have in the operating room, and we are just monitoring the patient to make sure that they're comfortable and that they don't need extra support throughout surgery. The circulating nurse does document everything that happens in the operating room, and they're also keeping an eye out on the TV monitor to make sure there's nothing that they need to go into the clean utility room to grab for the surgeon. So they're listening to the surgeon as far as what that surgeon may or may not need, and the scrub tech. Those two are communicating closely, and then the circulating nurse just gets everything that's needed for surgery. Patients typically pretty quiet during surgery, but should they need anything, the circulating nurse would obtain that. The majority of our patients are pretty comfortable during surgery. It's typically easier than they thought it was going to be. We try to tell them that. We try to tell them that they're going to experience some pressure and some cold water splashing sensation, so they're aware of that. We're going to tell the patient to let us know if they need to cough or sneeze, to communicate anything that they may need during surgery using their words. We let them know in the pre-op area should they that what they're going to feel, what they can expect in the LensX room, what they can expect in the operating room, what they're going to feel, and what they're going to see. I typically tell patients that they're going to be looking at a super bright light, and they're going to see a bright light and shadows, and that's pretty much what they're going to see for that 10 to 15 minutes while they're in the operating room. I let them know that they're going to feel some pressure, and they're going to feel some cold water splashing sensation, and that's about it. Should they feel anything more or need to communicate with us, we just need them to use their words. I think it's patient care is number one. So if you take care of the patient, I feel like the majority of our patients are very nice to us because we in turn treat them with respect. We show them, give them 100% of our attention. The nurse that is with them in pre-op stays with them. And I think it's important. We assign a pre-op role, we assign a take-in role, a discharge role, a circulating role. And so that patient kind of knows that nurse that gets them ready is going to stay with them to make sure they're fully comfortable, they have the right dose of Valium on board before they ever go to surgery.
Before surgery, I'm responsible for opening up all the materials required for surgery. We use everything's basically single use, so everything that we open is for each patient. So every viscoelastic, every pack that we use is for each patient. So they're all set up for the day. And then other than the physician, I'm the only other sterile individual in the operating room. I'm responsible for gowning and gloving myself and preparing within minutes what's ready for the case that's about 12 minutes long. I take all of the materials, stay sterile, help and anticipate the surgeon and what they need for each case. So, and then break it all down and then do it all over again. The physician would somehow have to be responsible for setting up his own case, staying sterile, keeping everything in mind that he needs to concentrate on for the patient, which is what lens, where I'm sitting, concentrating on surgery itself, because him or her would be distracted, changing cannulas, switching from phaco to IA, all these things he or she would have to do all by themselves. So it would slow down surgery tremendously. So if the scrub tech weren't present, there would not be essentially a right-hand man for the surgeon to be able to concentrate on what they should be concentrating on, which is performing a safe but efficient procedure, which should theoretically only be 12 minutes long. So without a scrub tech, it would at least, I would assume, double the amount of time. And I think just jeopardize a lot of things, meaning safety, efficiency, and all those sorts of things. Because a poor circulating nurse shouldn't have to worry about that either.
Well, I didn't really know what to expect, except somebody was going to be poking around in my eye, and I thought, oh my gosh, how am I going to keep my eye open? And of course you put the clamp in the eye, and by this time the Valium is taking effect, and I guess I felt, I don't know if cheerful is the right word, but I certainly felt very calm. And you see in the eye, just a lot of lights going on, and didn't feel anything other than that. So I was really surprised at how, I don't know if easy is the right word, but how calm the whole thing was.
Fine.
So, it's none of this, somebody's going to stick something in my eye, and what's that going to feel like, and how am I going to react to that?
No pain.
No pain.
Okay. That went well. Thank you.
Thank you.
We bring them out and we start checking blood pressures. Typically we get 3 to 4 readings, assuming that their blood pressure is within normal limits. The problem being when it's not, and so that can be a very time-consuming process if the patient needs to be treated with nifedipine. We go over any questions that they have. Typically it's about a 15-minute process, 15 to 20 minutes, assuming that everything goes smoothly. Opportunity for things to derail is with their blood pressure or their ride is MIA. So those are our 2 big struggles with discharge. We tell patients to anticipate being here, that 2 hour. So it depends on, are they the first patient? Probably less than 2 hours. Are they later in the game?
Hour and a half to 2 hours. So later in the day, we call the patients to check on them. We remind them of their follow-up appointment, their eye drops, make sure that they've started their eye drops, answer any questions they have.
Remind them of their follow-up appointment.
Yeah.
The optometrist and ophthalmologist work together for the postoperative care.
Usually when they schedule that postoperative appointment, I know that they tell them that they're going to see me first and then you'll see them too. So I come in and I usually already know the chart, so I already know who I'm seeing. But I just come in and refract them and then look at them under the microscope, check their pressure, look for any kind of pathology, make sure all the incisions look closed. So we discuss kind of their overall clarity, what they're feeling about their vision, what their expectations are, so that we make sure that we're in check for the second eye, kind of a double check system. We kind of go over where they're at today, and if they're happy overall, how they're feeling. And then if it's the first eye, we need to make plans for the second eye, make sure that if they're wanting a little more near vision, that we need to let you know. If I'm refracting some plus, what kind of adjustments we might want to make. Or if I'm refracting a lot of minus, we kind of talk about what their expectations are, if they need more distance, just what kind of adjustments we'll make for the second eye. And if it is the second eye, we kind of talk about how happy they are overall. And so if it's the first eye, I come in and I refract, see overall what we're getting on vision, how happy we are with vision, what our expectations are, what the goal is in the end with the healing process. If we're both happy and in agreement, then I'll just see them again at the 1 month, and at the 1 month we'll see where we're at, and usually we're really happy. It's pretty easy. And then I just check pressure, look at them under the slit lamp, make sure there's no pathology. I think I play a pretty good role in refractive care, making sure that visual outcomes are up to expectations. At that postoperative visit, I usually then take over their long-term care for their routine eye exams.
It was really quite marvellous the way you get treated and the way that they pay attention to you, and it seems so smooth and regular, so you don't feel like, what happens if the staff had a bad night the night before, it was just calming, the whole atmosphere. So I congratulate you and obviously the team you have here for being so professional and nice.
Okay. Well, thanks so much. I guess that's it.
Yeah, you're welcome.
That's it. After that, behind the scenes, there's the director of insurance that reviews the charges, submits insurance claims.
So my role at Austin Eye is the director of insurance. So basically I am the auditor of all ledgers. So basically any visit or service a patient has, I double check to make sure by the time it makes it to insurance it was billed and coded correctly. So if a patient comes in, upon first entrance they deal with the receptionist. If the receptionist has any questions about coverage or
anything about the card itself, they'll come to me or one of my counterparts. So we try to filter out any insurances that they wouldn't have coverage for. So for this patient, he would have a preoperative visit, the service itself, the cataract surgery, and then his post-op visit. So we check that all of these services are billed correctly. Since he was a new patient, we have to go in and double check that all insurance and demographic information is entered correctly, or else it'll have an issue when it's submitted to insurance. So basically, upon checking everything, I then send these claims to insurance. And then we wait for payment and processing. If for some reason the insurance paid incorrectly at the wrong rate, they denied or whatnot, then I have to essentially fight the insurance to get the correct payment, whether that's for the clinic's payment and reimbursement or for the patient. We have to audit each claim to make sure it was billed and paid appropriately. If it wasn't, we fight it, and if it was, then the patient may or may not be due a credit or a bill. My level of involvement is with the patient's account. So basically, we want to make sure that the patient is aware of all charges ahead of time. We don't want the patient to end up with a bill at the end. Ideally, the patient would have a $0 balance at the end. So that's why all these steps are so important, to make sure that everything is done correctly. So basically, when I'm looking at the charges in the ledger, I have to make sure that the amounts collected versus what's being billed to insurance makes sense for that particular insurance. We have Amanda who actually does the pre-certification, but I look at the ledger before it's sent to insurance to make sure what's been done makes sense. If I see a charge in the patient's ledger or a credit, I have to investigate it. I try to investigate everything beforehand so that it's not just a random balance at the end. When a patient comes in for their pre-op, that is sent to insurance a day or two after, and then when they're scheduled for surgery, that payment may come in before their surgery is actually sent. So we look at the balance or credit to see if it can be applied to the next visit, so that basically they don't end up with a bill at the end. Also, if they have a credit, we like to apply it towards surgery if possible. But basically our goal is to make it where the sum total at the end is $0. So I handle the billing for both the professional and facility claims. So any claim that a patient has at our office is I look at. So since Austin I has our own ASC surgical center, we bill both the professional and the facility claim. So we're all inclusive at this practice. When we do a pre-certification, we should know the overall total. There's no hidden fee. So basically there are different requirements for professional versus facility claims. There are modifiers that have to be added to surgical claims to get them paid. Each insurance has a different requirement. So one may require a modifier that the other doesn't require. So we have to have knowledge about how to bill these claims. If the insurance denies for incorrect coding, then we have to go back in and either correct the claim or call the insurance or write an appeal to fight them for payment. The goal is to submit the claim the day after the patient comes in, whether that's their preoperative visit, their surgery. The goal is to submit it the day after for the quickest processing. Each insurance has its own processing time. Medicare's typically takes 2 weeks. Sometimes, for example, Aetna could take 4 days or several months. It really depends. Processing of a claim means that they send us an explanation of benefits, and along with that they send payment or denial to the clinic. So we want the quickest turnaround time both for the practice getting payment but also for the patient so that their claims can be closed. So insurance is tough, it's complicated, and if all of the steps are done correctly along the way, it makes this the easiest and the best outcome for the patient possible. So if anything is messed up along the way, it can cause issues down the line. So some claims could take 6 months to process if insurance processes incorrectly or if we didn't have the correct insurance information. So that's why we always try to validate the insurance and all of these things to make sure it's as streamlined as possible for both the patient and the clinic.
Then we wait 2 to 4 weeks. Payment is received and processed by administrative staff.
We receive payment from Medicare electronically through an electronic funds transfer. So it goes directly into the Austin Eye bank account, and then we receive a remittance, called a remittance, that shows, this check that's in the bank account included payment for all of these patients. And then we run it, and it posts automatically to all of the CompuLink accounts. We get a printed out document and we verify patient by patient, line by line, that it was correct. Because sometimes when anything's automated, you always want a human double checking it. So I receive the remittance slip or receipt that shows Medicare paid us this much money and we documented it in CompuLink on this day. And so the insurance team will do, a lot of those remittances. They'll post a lot of those remittances each and every day. I get the receipt of those, and then I make sure that the money balances, that what I've received is actually what shows in the CompuLink report. And I do that for the electronic funds transfers, for checks that are from insurance companies and patients, cash payments, bill pay, credit card slips, each type of payment we receive, I verify that it's accurate on the daily payment report.
This is what it takes to see and treat one patient. And the bottom line is, it takes a great team to make this process successful. Thank you.
We see more than 10,000 patients and perform over 3,500 surgical procedures annually. I want to personally thank each of our wonderful staff members who work tirelessly to create a great patient experience and provide great outcomes for all the patients that choose Austin Eye for their eye care. Our motto is our vision, perfecting yours. It is our outstanding team of professional staff and doctors that make this possible. Thank you.